Good evening, everyone listening tonight and watching the webinar. Traditional, but you know what's happening on Wednesday. We have a webinar presented by ESGE, and tonight we have another ESGE Papers of the Month session, evidence-based medicine in the endoscopy suite. My name is Siersema, and my co-chair is Professor Helmut Messmann from Augsburg, the president of the society. Tonight we have two excellent papers, one paper from endoscopy, another paper that was or is online already available and will be published in GUT. The first paper is on Barrett's esophagus. The second paper is on the role of MRCP in patients with gallstone disease or stone disease in the biliary tract. And I think these are two very excellent papers. Of course, as usual, when you have any questions, please use the Q&A box. And having said that, again, a very warm welcome for everyone who's joining just now. And we will start with the first presentation. And that first presentation is being presented by Pouw. And Esther Nieuwenhuis will join us later on because Rose is not available tonight, but the presentation will be done by Rose. And the title of the paper coming from endoscopy is the impact of expert center endoscopic assessment of confirmed low-grade dysplasia diagnosed in community hospitals. Rose.
Hello, my name is Pouw. I'm a gastroenterologist at the Amsterdam University Medical Centers, and it is my pleasure to present on behalf of my co-authors our paper on the impact of expert center endoscopic assessment of confirmed low-grade dysplasia diagnosed in community hospitals. We know that expert pathology confirmed low-grade dysplasia is the strongest predictor of progression of Barrett's esophagus to high-grade dysplasia or esophageal adenocarcinoma. Therefore, our Dutch guidelines recommend that patients with a confirmed diagnosis of low-grade dysplasia are referred to an expert center for a dedicated restaging endoscopy. Because these patients have an increased risk for malignant progression, and therefore they may benefit from a dedicated restaging endoscopy to detect any early visible lesions at a stage at which they can be treated endoscopically. And also in case of a repetitive diagnosis of low-grade dysplasia, prophylactic ablation can be considered in these patients. The aim of our study was therefore to evaluate the diagnostic value of this restaging endoscopy performed in an expert center for patients that were referred with a diagnosis of confirmed low-grade dysplasia. This was a retrospective cohort study in the Dutch Barrett Expert Center cohort that was recently published elsewhere. And for this, it's good to know that since 2008, in the Netherlands, the care for Barrett esophagus patients with dysplasia or early esophageal adenocarcinoma is centralized to one of the 9 Barrett Expert Centers. In these centers, 1 to 2 experienced pathologists and endoscopists work who have had a joint training program. Also, these centers work using a joint treatment protocol, and they have quarterly meetings to guarantee homogeneity in treatment and follow-up of the patients. For this study, we included patients who had flat Barrett esophagus, so that meant no visible lesions, but with low-grade dysplasia detected in a community hospital. Also, the low-grade dysplasia had to be confirmed by expert pathology review, and the patients had to be referred to one of the Barrett Expert Centers between January 2017 and October 2019. We excluded those patients who had a visible lesion described in the community hospital. The pathology review for this study was performed by an expert panel that consisted of 5 expert pathologists. And when the patient was referred to the Barrett Expert Center, a restaging endoscopy by one of the expert endoscopists was performed within 3 months as it is advised by the current guideline. Endpoints of the study were, first, the proportion of patients with high-grade dysplasia or esophageal adenocarcinoma or visible lesions during the restaging endoscopy at the Barrett Expert Center. Second, the proportion of patients with high-risk esophageal adenocarcinoma found during restaging endoscopy. And third, the proportion of patients who had an indication for endoscopic treatment, also including prophylactic endoscopic treatment, upon restaging. In total, we identified 258 patients who had a confirmed diagnosis of low-grade dysplasia. Of these patients, 248 were referred to one of the Barrett Expert Centers. So 10 patients were not referred and they remained in the care of the community hospital for varying reasons. For example, limited life expectancy or because of their own preference. Of these 248 patients that we assessed, the majority was male, the median age was 69 years, and patients had a median Barrett length of C3-M5 according to the Prague classification. 60% of these patients had a history of Barrett surveillance endoscopies for a median duration of 7 years. And the restaging endoscopy in the Barrett Expert Center was performed a median of 3 months, so 0 to 3 months after referral, after the endoscopy in the community center was done. In this figure, I will take you through the results of the restaging endoscopy at the Barrett Expert Center. So of these 248 patients, 23 had an endoscopy where no visible lesions were found, and there was also no dysplasia found in the biopsies that were taken, of course, according to the Seattle protocol. So this was in 9% of the cases. In 168 of the patients, there was a second diagnosis of low-grade dysplasia, of course, again, confirmed by an expert pathologist. Of these cases, 12 also had a visible lesion, but in the end that showed low-grade dysplasia. And all in all, these patients, 142 of these were treated with endoscopic resection or radiofrequency ablation or a combination thereof. And interestingly, 57 patients, so 23%, had high-grade dysplasia or cancer detected during the restaging endoscopy in the Barrett Expert Center. Most of them had a visible lesion, and 55 patients were treated with endoscopic resection and ablation. Here you see an example of a patient who was referred with low-grade dysplasia. We retrieved the endoscopy images from the referring hospital. No visible lesion was described there. But during the restaging endoscopy, the expert endoscopist did see a visible lesion, as you can see in the circle. This lesion was resected during an EMR procedure, and the resection specimen showed a submucosal adenocarcinoma. So in conclusion, our study showed that patients with flat Barrett's esophagus with a diagnosis of low-grade dysplasia should have external expert pathology review, and in case of confirmed low-grade dysplasia, patients are referred to a Barrett Expert Center to have restaging endoscopy within 3 months, and we found that only 9% of patients had no more dysplasia during the restaging endoscopy. 68% of patients had a second diagnosis of confirmed low-grade dysplasia, and most importantly, 1/4 of the patients had high-grade dysplasia or cancer during the restaging endoscopy in the expert center. And all in all, this meant that according to the current guidelines, 91% of patients had an indication for endoscopic treatment, either for high-grade dysplasia or cancer, or for a repetitive diagnosis of low-grade dysplasia. So our results endorsed the advice to refer patients with a confirmed diagnosis of low-grade dysplasia, also in the absence of any visible lesions, to an expert center for restaging endoscopy. With that, I would like to thank you for your attention. And my colleague and first author of the paper, Esther Nieuwenhuis, will engage in the discussion later on. So thank you again.
So thank you, Ruth, wherever you are right now and can't hear you, but we're happy to have Esther Nieuwenhuis here for the discussion afterwards. But before we discuss this paper, I think as we have this webinar, we have another expert. The Dutch group mentioned the endoscopy expert center, expert pathologist. Now we have an expert from Germany, Oliver Pech. He is also involved in the guidelines, in the German guidelines. And I think it's very important to have now a look at this important paper. What we have seen now from the Netherlands is it's the same for every other European country, for Germany. So Oliver Pech, welcome to give us now your view. Dr. Pech is head of a department in Regensburg, St. John's God Hospital. This is a hospital where I started my career as a fellow. And if I wouldn't move away from Regensburg, Oliver Pech would be my boss. So then let's introduce now Oliver to give his view and the discussion after that. Thank you.
So I would like to comment on this excellent paper published by the Amsterdam group on the risk of low-grade dysplasia. You heard the results, and I want to add a few comments. So I think, again, it's very important to, again, mention the conclusions from the study, at least that I draw. I think it's very important to know that when you have a histological confirmed low-grade dysplasia in Barrett's esophagus without a visible lesion sent by community hospital endoscopist, about 1/4 of patients reveal high-grade dysplasia or Barrett's adenocarcinoma and a visible lesion during endoscopy at an expert center. So this again underlines the importance to send patients with a diagnosis of dysplasia and also low-grade dysplasia in Barrett's esophagus to experienced centers. So this also low-grade dysplasia is a relevant diagnosis that should be referred. In addition to that, what we already know, that low-grade dysplasia has a relevant risk of progression. We also know now from this study that about 1/4 of patients have a lesion within the Barrett's with higher grade of dysplasia. So the strength of this study is that the Amsterdam group really did a meticulous search of the national database, and dedicated researchers were involved who are very experienced. Another strength of the study is that pathology was standardized in this study, and there's an expert panel of pathologists that evaluated all slides with low-grade dysplasia again and confirmed the diagnosis of those patients who were included in the study. And there are also standardized expert centers in Barrett's. There are 9 expert centers in the Netherlands, and they all have to fulfill certain criteria to be an expert center. So there's also a very homogeneous expert center. There are very homogeneous expert centers in the Netherlands. And another very important thing is that there's a large patient number included of 249 patients in the study. The study also, of course, has limitations. It was a retrospective cohort study, and there is always the risk for selection bias. And also it could be that because of the endoscopist in the expert center was aware of the diagnosis of a low-grade dysplasia, they might have inspected the Barretts more carefully in order to find a visible lesion. And another possible limitation is that not all patients with low-grade dysplasia in the Netherlands during that time have been referred to an expert center. There might have been patients that might not have been referred to an expert center and might not have been included in this analysis. And also the researchers also searched the pathology database. Not all patients might have had an expert pathology review and therefore would have not been included in the study. So I would like to put the results of this study into a context. It's important to know that similar results were recently confirmed by an Australian study. The Australian study had 75 patients with confirmed low-grade dysplasia, and 20 out of those 75 patients had high-grade dysplasia or adenocarcinoma on endoscopy in an expert center. And 52% of those with confirmed low-grade dysplasia had a visible lesion within the Barrett's esophagus. Also interesting is that in another study it has been shown that even the diagnosis of indefinite for neoplasia seems to have a higher risk for the presence of a prevalent neoplasia. In a recently published study, the risk was 9.5% to find prevalent neoplasia, and there were 242 patients included and 23 had a prevalent higher grade of neoplasia in the study. In this study by the Amsterdam group, all low-grade dysplasias were diagnosed by random biopsies, and the question arises, of course, whether the lesions that were later seen in the expert center were biopsied, or the low-grade dysplasia that was diagnosed in those random biopsies was taken somewhere else within the Barrett's esophagus. And I think it's more likely that low-grade dysplasia was diagnosed somewhere else in the Barrett's esophagus, and that this low-grade dysplasia represents the field defect and the neoplastic progression of the whole Barrett's esophagus. Recently, it has been shown that also lesions or lesions containing high-grade dysplasia and early adenocarcinoma are more likely seen in expert centers compared to community-based endoscopies. And in this study published also by the Amsterdam group, visible lesions were seen in 60% of patients versus in the expert centers in 87% of patients. So again, this underlines the importance to send patients with a diagnosis of dysplasia or neoplasia in the Barrett's esophagus to an expert center. The current ESGE guidelines recommend staging endoscopy in case of confirmed low-grade dysplasia in an expert center within 3 months after diagnosis. And longer time intervals might have the risk that there is a progression of those lesions. And we saw, as already mentioned, 1/4 of patients with high-grade dysplasia and adenocarcinoma. And of course, there is a risk of progression in those patients with more advanced lesions when the time frame is longer than 3 months, for example, 6 or 9 months. And very important to say is that if patients would not have been referred to expert centers by the community hospitals, 1/4 of patients with low-grade dysplasia would have been undertreated with RFA, which would have been the recommended guideline diagnosis. Thank you very much.
Okay, We are back again all together for the discussion. Thank you, Oliver, for your nice comments. There are a couple of questions coming in right now, but I would like to start maybe with one stupid question from my side. You mentioned that 9 expert centers in the Netherlands were participating, and when Oliver and I were involved in the German guideline, we also were discussing about expert center. You have 9 expert center in a country with 70 million people. In Germany, we have 80 million, and I calculated we must have in Germany then at least more than 40 expert centers. So I'm wondering, how is the definition for an expert center in your country? And then the question to Oliver, how can we, can we have the same conclusion at Netherlands in our country for our guidelines? So question to both of you.
So maybe
Thank you, Helmut.
Yes.
Yeah, thanks. Yeah, we indeed have 9 Barrett expert centers in our country, where the care is provided by 1 or 2 experienced pathologists and endoscopists. So those experts follow joint training programs, they adhere to a joint treatment and follow-up protocol, and they participate in quarterly meetings to guarantee the homogeneity. So they do have to fulfill some points. An expert center needs a caseload of at least 10 new patients with Barrett's neoplasia per year. Their high definition endoscopes have to be present. There have to be multidisciplinary meetings with gastroenterologists, pathologists, oncologists, and surgeons need to be facilitated. They do need to have access to upper GI surgeons, and all the patients with Barrett's neoplasia have to be registered in a prospective database. So to all those points, an expert center need to fulfill.
So far, we don't have this in Germany.
So Oliver, how are you going to do this in Germany?
Yeah, that's a big problem in Germany because we could never agree in the guideline committee on the definition of an expert center. That's the big problem. There was always the discussion, can we really give the recommendation to treat those patients only in an expert center, or could larger hospitals do that without defining what is an expert center? So we unfortunately don't have this definition as a real guideline recommendation.
So maybe that's then something to work on.
Maybe for our next guidelines.
Maybe I can add another question that's maybe also related to this, and that's of course the question: why are centers missing these lesions in Barrett's esophagus? Is it because they do not spend enough time? Is it because they do not have the correct endoscopes? But what is the idea there?
I think detecting a Barrett's lesion is just very difficult. They're subtle. Most of them are not a real visible lesion, but can be flat actually. Sometimes there's reflux esophagitis, what makes it more difficult to detect a lesion or detect dysplasia. And maybe time is also a factor. I think in an expert center, we have a bit more time, and we do know that a patient has Barrett's esophagus, and there are special programs on our endoscopy programs for Barrett's patients. So I think that plays a role as well.
Well, then of course, maybe to add to this, what could be the role for AI then in these centers? Could that be helpful, you think?
Yeah, that's a very interesting question. I think AI can play a role in community hospitals to just help the endoscopist detect possible dysplasia, so that biopsies are taken from the right place.
Excellent. That's one of the maybe the explanations, or maybe also one of the solutions for this. Huh?
Yeah, I totally agree.
Maybe we should have a look in the Q&A box.
Who should perform surveillance then? Is the question. must be performed in expert centers only, or can done everywhere? From if you have this situation, because one question is always how many community units missed low-grade dysplasia. Are there any data? Do we know this?
I think from our data, there are a couple of community centers that missed dysplasia. Our data shows that that there's a quarter of patients with high grade. So I think, yeah, low grade or any kind of dysplasia was missed in the community. Yeah, should we perform surveillance?
You received the selected group of low grade, but you cannot exclude those patients who had the missed low grade dysplasia because they didn't send it to you or just by chance. So that could also happen, right? And yeah. I completely agree that Peter, AI and we have all the system in Augsburg developed. AI will be also hopefully assist endoscopy similar to lower GI. No? It will come everywhere in the GI tract. So that's for sure one option. But I think the message is clear. Expert centers must do this difficult job, and the patient should be referred because they have equipment, they have more experience, they have high cases, as you said. Yeah.
So Helmut, there's one paper showing that about 25% of Barrett's cancer or high-grade neoplasia are missed.
Yeah.
So I think this you commented it totally correctly.
Is it crucial that expert center must also do resection, or is it enough to say this expert center is fantastic in diagnosing, and within this group of 9 expert centers there are 2 groups for therapeutic? So is there a difference, or would you say an expert center is also doing a great job in endoscopic therapy?
I think in our country, the group is quite small and they all participated in the joint training programs. So I think all endoscopists are excellent in performing the resections.
Well, one thing is, of course, spending enough time during the endoscopy. Do you have any information on the fact whether patients are undergoing surveillance in time, or is it also extended, or is it not done in the right way? Is there any information available on that?
We didn't look at the surveillance data in this paper on that actually. I think we have quite a strict surveillance program, and the first surveillance endoscopies are performed in the expert centers themselves. So I think the surveillance is quite strict after detecting dysplasia or treating.
Would you recommend as an expert center to use acetic acid routinely and the cap for those patients? And do you also measure the time of inspection of 10 centimeter Barrett's?
Sorry, I didn't quite hear the first.
Do you recommend for, or do you as an expert center use acetic acid for the diagnosis? And do you use a cap on the scope to improve visibility? Is this crucial? Is this important?
We almost always use caps. I know I do not perform endoscopies myself yet, but I have seen a lot actually. So we always use caps, and we do not use acid during Barrett endoscopies.
And do you also monitor the time of inspection of your Barrett segment? Is it monitored?
Yeah.
We have data. We should spend more time, but is it documented?
It is documented actually. Yeah.
That's great.
Well, that's true, of course, but I also know that in many centers, the list for upper endoscopy for gastroscopy are very busy. So you can also imagine that all these issues are not taken too serious always, and that is, of course, also a problem. Well, I think we discussed this very interesting paper very well. I think it's a very interesting paper. It also shows how important quality in inspection of the Barrett's is. And it highlights also that quite a few patients that have low-grade dysplasia also may have more advanced neoplasia already in the Barrett segment. Helmut,
I hope it will influence the German guidelines in our recommendations.
I hope so too.
Well, at least you can show this video maybe during the guideline session in the future.
Exactly.
So maybe we should move on to the next paper. Thank you both for joining us.
Okay, thank you. So then let's continue. And now it's my great pleasure to introduce our next speaker, Professor Nagesh Reddy from Hyderabad. I mean, to introduce Dr. Reddy is like to introduce the Pope. It's really not necessary. He has one of the largest endoscopy center worldwide, a huge experience in ERCP. And the topic of this paper is EUS versus MRCP to perform ERCP in patients with an intermediate likelihood of choledocholithiasis. It is the first randomized controlled trial on this topic, and the ESGE guidelines recommend in this situation EUS or MRCP, and now Dr. Reddy gives us the answer, what is better. So Nagi, thank you for giving us the opportunity to present your paper here with you as a senior author. I know it's quite late in India, but let's start first with your presentation, and after that we have a discussion, a comment, and then a discussion.
I'm Dr. Nagesh Reddy from Hyderabad, India. I am here to discuss our paper on the role of endoscopic ultrasound versus MRCP in patients with suspected choledocholithiasis, published in Gut this year. In patients with gallbladder stones who have suspected choledocholithiasis, LFT and ultrasound are normally done. A recent ESG guideline suggests that these patients should be divided into 3 categories. Those with low likelihood of common bile duct stones, who can then directly go for a cholecystectomy. Those who have a very high likelihood, who would then go for an ERCP followed by cholecystectomy. However, there are a group of patients with intermediate likelihood of CBD, and in these patients, to avoid unnecessary ERCPs, we would like to do an EUS or an MRCP before doing an ERCP. However, which investigation should we do in these patients before ERCP? And this is not answered in the literature. In fact, if we look at the literature, there are 2 studies. Most of them are related to small studies. In 2015, a Cochrane review suggested that two studies which actually had a direct comparison of endoscopic ultrasound and MRCP, but unfortunately, even the high likelihood criteria were included. Similarly, in a meta-analysis of 5 head-to-head studies published in GIE, there is no uniform standard reference, and majority of the studies had a small sample size. So, in the literature, there is no study, RCT, to compare endoscopic ultrasound with MRCP to make an indication for ERCP. So, therefore, we decided to study this problem with an RCT, and the aim was to evaluate the sensitivity of EUS and MRCP for diagnosing choledocholithiasis in intermediate likelihood group of choledocholithiasis as per the ESG risk stratification criteria. The study was done in the AIG hospitals between November 2019 to May 2020. We selected patients with intermediate likelihood of choledocholithiasis for the study and randomized them in 1:1 block randomization of 8. In patients who had an ERCP done and were negative for any stone disease, we followed up to 6 months, and in the interim period, if these patients developed any cholangitis or suggestive of stone disease, an ERCP was redone to look at this and remove the stones. Now let's look at what happened to these patients. Of the 266 patients, they were excluded 42. 224 patients were randomized to either EUS or MRCP. None of the patients were lost for follow-up, and all of them were analyzed. And this was the result. You can see from these results that 44 of the 112 patients who underwent EUS were positive compared to 60 in the MRCP group. So, slightly larger number of the MRCP group were positive. When we looked at false positive patients, that is EUS or MRCP showing a positive stone but ERCP being negative, they were almost equal in both groups, 1 in EUS and 2 in MRCP. However, when we looked at false negative group, that is EUS or MRCP were negative, but on follow-up, these patients subsequently developed a CBD stone which was removed at ERCP. There were 2 in endoscopic ultrasound and 5 in MRCP. Ultimately, 65 patients in EUS group were true negative and 45 patients in MRCP were true negative. On statistical analysis, if you look at the sensitivity and specificity, they were similar in both the groups. So was the positive predictive value. However, the negative predictive value, Alvarez, was slightly better in patients in EUS compared to MRCP. Now, this could be because of a slightly higher number of patients who've been enrolled in the MRCP group, and because of the randomization, this was not under control. So, this may not actually represent a true difference. Subsequent to our publication of the paper, there was a letter to the editor which pointed out at 3 limitations. First was that this was a single center study. In our institute, the expertise for both EUS and MRCP is equally high. So, in a real life situation, can this be duplicated with a multi-center study? Of course, this was a good suggestion, but unfortunately, this type of study would be extremely difficult to duplicate in a multi-center study, setting. What about the size of the stone? It's believed that stones less than 4 millimeters are easily detected at endoscopic ultrasound. So, therefore, there may be an advantage to do EUS in stones which are very small compared to MRCP. We actually didn't factor this in our study, but when this question came, we went and looked back at our case and found that this 4 millimeters, majority of the patients were above 4 millimeters, but even in those patients who had less than 4 millimeter stone, there is no difference in EUS versus MRCP. And finally, one of the questions that was asked was, what was the rate of cholecystectomy after ERCP? Because it's believed that if you extend your cholecystectomy date too long, there's a potential possibility that these stones can slip again into the CBD, giving a false negative impression. Again, we didn't factor this in the study, and when we looked at our study, we found that majority of our patients had a cholecystectomy done after 4 weeks. And therefore, some of these limitations to our study have been answered when we actually did a post hoc study of our cases. In conclusion, our study suggests that both endoscopic ultrasound and MRCP are equal in terms of specificity and sensitivity when trying to decide whether these patients should go for ERCP or not. Although, as we discussed earlier, endoscopic ultrasound had a slightly higher negative predictive value. But ultimately, whether you do an EUS or ERCP in a patient with intermittent likelihood of CBD stone would depend upon the local expertise, the patient's condition, availability of resources, and of course, also the patient preference. Thank you very much.
Thank you very much for the presentation of this interesting study with potential, of course, clinical interest for people that are treating and seeing these patients in clinical practice. And I'm sure that there are quite some questions at the end of this later on during this session. But first, I would like to invite Dr. Andrea Annaloni to comment on this interesting paper. Dr. Andrea Annaloni, we all know he is from Italy. He's now working in his own institution. He's the chief of the department, and he looked into detail in this gut study, and he will present you his comments to this study.
Hi, I'm Dr. Andrea Annaloni. I'm the director of the Gastroenterology and the Digestive Endoscopy Unit at San Matteo Hospital, Pavia, Italy. I've read with great interest the paper written by Nagy Reddy and co-workers addressing a very interesting topic: how to better diagnose the suspected choledocholithiasis in patients with intermediate risk. Those are my competing interest disclosure. And in this nice paper, we have different strengths of the study. First of all, this is the first randomized controlled trial on this topic. Second, it has a large sample size, enrolling 266 patients. Moreover, the study had clear and restrictive inclusion criteria. And even more important, the patients were followed up for 6 months after the procedure. Of course, this is a single center study that was conducted in a very high volume and expert center. But in my opinion, this could be a relative limitation of the study. The authors conclude that sensitivity and specificity of both EUS and MRCP are comparable in case of suspected choledocholithiasis in patients with indeterminate risk group. Moreover, the choice of performing one procedure or the other should be based either on local expertise, the availability of the procedure, and of course, the patient's preference. But I have a first question to the authors. If I have both with similar expertise in my hospital, which one should I choose? Probably the answer is that I have to choose on the patient conditions, on the patient's characteristics, and maybe also on the costs of performing one or the other. Let's see the pros of performing EUS. EUS has a higher negative predictive value and positive likelihood ratio in comparison with MRCP. Moreover, ERCP could be conducted in the same session with the same sedation, saving time. And this could be another interesting point, if during the EUS procedure I find something incidental, I can perform even FNB for a better diagnosis. Of course, we have some cons. That is that the procedure is invasive because it's an endoscopic procedure, needing also sedation. Anatomically, if I found a duodenal diverticulum, this could affect the outcome of the procedure. And of course, also in altered anatomy, I can have some problems in reaching a good position for studying the common bile duct. As far as the MRCP is concerned, we have this procedure more available on the territory. Moreover, it's a not invasive procedure, does not need any sedation. And of course, it could be conducted also in patients with altered anatomy. Nevertheless, even MRCP has some cons. First, it doesn't allow to perform ERCP in the same session. Second, could be a problem in patients suffering from claustrophobia, in obese patients, and of course in patients with some metal clips or prostheses. So, probably to answer the question, what should I choose if I have both of the procedure available? Probably the patient condition should drive our decision, choosing on the basis of the characteristic of the patient. But if you ask me my preference, I would definitely choose for the EUS approach, because I think that having the possibility to perform ERCP straightforward is a very, very big advantage. Of course, we need to analyze the costs, and probably these are different from region to region. So I would like to thank you for your attention, and I'm really interested about the comment by Nadi Reddy on this topic. Thank you very much.
Well, thank you very much, Andrea, for this thoughtful comments on this paper. Nagi, do you feel like answering already immediately right now?
Yeah, I think this is a very important comment that Andrea had made, that if you had a choice, what would you do? Of course, we aimed the study mainly to look at, in the literature, there's no answer. And we want to try and answer this question, which would be better? Because if you look at the ESG and also ASG recommendations, both of them recommend US or MRCP. But if as an endoscopist, and I think in most endoscopy centers, one would probably prefer an EUS, everything else being equal in terms of cost and so on, mainly because at US, it's under the control of the endoscopist, and then you do the procedure and immediately, if it's positive, go ahead and do an ERCP. So I think logistically, an EUS, like Andrea said, would probably be the preference of most endoscopists. But if you look at all the centers as a whole, for example, these patients may be in centers where ERCP expertise is not available or US is not very good, and then the referring doctor would first see whether MRCP rules out this condition or not before sending the patient to another center. So in this type of situation, where expert endoscopic center is not the base for the patient, I think MRCP would probably be the preference, unless this patient has claustrophobia or clips or so on. So I think this is an interesting question, and we are very sure that we've answered at least the scientific part, that they're equal in terms of sensitivity and specificity. But our own preference, like Andrea's, would be in our center that having both with equal cost, we prefer US over MRCP.
Thank you.
Yeah, I think this was a very wise comment from Andrea to a very important paper from Nagi. Nagi, may I ask you, Andrea said, well, he would go for US. I expect you, in your clinical practice, are you also in favor of more doing the US approach?
Yes. Yes. We, in our hospital, we would do an US approach first, because we have the expertise available all the time. And the advantage also is that if we find something, we can go ahead and do ERCP and remove the stones. The only trade-off is that US in our center is slightly costlier than MRCP. So if it came to the cost factor, MRCP has slight advantage. The cost is at least half of US. But there may be centers where MRCP is costlier, so then that argument goes up. But in our center, we prefer US because under the same anesthesia, we'd go ahead and do an ERCP also and complete the whole procedure in the same sitting.
Yeah. I think I can confirm the same. We have almost the same situation right now in Germany. So over the years, the endoscopy centers, the experts go now for this approach, starting with EUS. If this is positive, then immediately doing the ERCP, because time is money, and you save time because the patient stays only stays not so long in the hospital. Yeah, that's true. How is it in your country, Peter? Is all of them more in favor of US, or what is it?
Increasingly also more in favor of EUS, and then followed by ERCP if indicated. And I think another issue is, of course, sometimes you don't see any stones, but you see an accidental finding, as was also mentioned by Andrea. And then you also can do FNA or FNB if whatever is needed at that time. So I think that's also an advantage of using EUS.
Yeah. So Peter, that is an important point. So when we actually, I didn't mention this in the presentation, but in our study, out of the 112 patients we had on both groups, in the US group, we found 5 additional findings. They were in form of a small subepithelial neuroendocrine tumors in 2 patients. 2 patients had diverticular, and 1 patient had incidental duodenal ulcer. So these were, whereas in the MRCP group, we had 1 patient who had duodenal diverticular, and 1 patient had a pancreas divisum. So they were not different statistically, but I think one additional advantage of EUS, you can, when you find additional lesions, you can take biopsies. Although in our patients, there was no difference in clinical outcome, what we found in terms of pre-ERCP investigation.
There are quite a few questions also in the Q&A box, and I think one question is, I think, very interesting, coming from Mariana Aravanitakis. She thanks you for the excellent presentation, and important question maybe, were there also patients with acute biliary pancreatitis in the cohort, And could the MRI give additional information on staging of acute pancreatitis?
Yeah, that's a very important question that Marianne has raised. In fact, in our study, again, we didn't factor this as part because we didn't want to contaminate the study and make it very pure. About 20% of the patients had acute pancreatitis, but the indication was only cholangitis for intervening in these patients. So if you do an EUS, of course, you get some additional information, but I think that should be another study where patients with EUS and cholangitis are being studied for ERCP intervention. And then you can discuss whether it's EUS or MRCP. In the present study, that was not factored into because I believe that in patients with gallstone pancreatitis, the only indication for intervention is going to be cholangitis.
Yeah, I think so, yes. And
Marianne is also asking about the consenting of the patient for both procedures. So I think it's important to inform the patient before you start with EUS that in case you have a stone, you will do the ERCP, otherwise you have some problems. Yes.
So I think consenting would be, we have a more general consent form where patient will be consented both for US and ERCP and an MRCP separately, because once we find something on US, we don't want to wait and come back again. We'd like to finish the procedure in the same sitting. And generally, our endoscopic ultrasonologists are also expert ERCPs. So it's the same group of people.
Yeah.
okay.
Also,
And how is that in Italy, Andrea?
yes, we have done a little work during a consensus, and we realized that we nowadays do not consent anymore just for ERCP or just for EUS. We consent it for a biliopancreatic endoscopy. This is because we are going to treat a condition and not to do only a therapeutic option. So this is true either for common bile duct stones or for pancreatic tumor. Moreover, I want to add something more on the very interesting discussion. I think that in gastroenterology is happening today what is happened 20, 30 years ago with transabdominal ultrasound. Now we are ready and we know how to perform EUS, and we are basically clinicians that treat this kind of patient and usually are on our beds. And I think that in a logistic consideration and also from the economical point of view, even if the MRCP could be less expensive, the advantage of having in your hands both of the procedure is extraordinary. Moreover, the timing of the procedure could even be more important because these kind of patients usually stay in the accident emergency department, at least in our country, for 1 to 2 days because you need to check if the LFDs are going down, if the clinical impact is reducing. But if you want to bring the patient in, you need to wait a few days until a bed is free. And we have done 10 years ago a small paper addressing this condition, offering to this kind of patient from the accident emergency department the EUS, the early EUS, among the 48 hours after the arrival in the accident emergency department. And that was very, very helpful in analyzing patients that need to be treated with ERCP, and they were treated immediately. And hopefully they were able to go home the day after, or patient with no stones anymore, so that you were able, in some case, to discharge the patient early. The last point, and this is, of course, because we are endoscopists and gastroenterologists, this is also the way for our units to organize better our resource, because this approach is working if you have EUS and ERCP available every day with the anesthesiologist. And this could even help in teaching EUS, in teaching biliopancreatic endoscopy, because you will have a lot of patients to treat. And I think, and maybe Nagy could comment on this, that to check with EUS if there is a stone or not is going to last 3 minutes just because you want to explain to the nurse and to your fellow. And I think this is also another very interesting point to discuss.
I think, Andrea, I agree with you that it's EUS examination of the CBD, especially in most of the expert centers, are very easy. It just takes 4 to 5 minutes to complete the procedure. So therefore, I think all of us have this tendency towards EUS followed by ERCP. But I think also if you look at the real life situation, there are many centers where you don't have a continuous pancreaticobiliary services all the days. Also, they don't have access to high-level expertise. I think in those type of situations, our study shows that you have an alternative. Okay, you do MRCP, and then you can decide if you want to send the patient elsewhere for ERCP. But otherwise, I think in all the expert endoscopy centers, I think there's no question that everybody will go for EUS followed by ERCP.
Like it says, an interesting question in the chat. Would it be possible to stratify between low and high risk of choledocholithiasis within the intermediate group and allocating MRCP for the low intermediate group and EUS for the high intermediate group? So can you stratify
no.
this? Is it possible?
No, I think that design would be faulty because we know that the incidence of choledocholithiasis in the low risk group where LFT is normal, ultrasound is normal, is extremely low. So there's no point in additional resources going into this, and this has been repeatedly shown by several studies. Similarly, in the high risk group, where an ultrasound demonstrates a stone or LFT is abnormal, and of course we have an age group in the ESGE criteria, in high risk group, the chance of a stone is extremely high. So I don't think we should allocate additional resources to these two groups and waste our time. And because the chance, the intermediate group is about 50% of possibility of a stone, this is where this important question comes, whether we should avoid unnecessary risk of an ERCP in the 50% of the patients, and therefore select this highly selective patients. So I think we should not attempt to do these studies where they're low risk or high risk.
There's another interesting question in the Q&A box. Can you comment on the chance of spontaneous passage of a smaller stone and the risk of overtreatment by performing ERCP right away? I think that's interesting. Maybe first, Andrea, what do you think?
Well, this is a very good point. Not only for the small stones, depending also on the timing you perform the procedure. Because if you have a biliary colic and you go directly for EUS or MRCP, you may see some stones that probably will spontaneously pass. Nevertheless, I think that the risk of having even small stones is much higher than the possibility for the stone to pass. This is a benign condition that, if it's not treated properly, could lead to very, very difficult condition. I want to remember that a possible complication is acute pancreatitis, and even if it's small as a percentage, this could bring the patient also to accident emergency department, to having a complication, and to go even to death. And this is very, very strong message because we are speaking about a benign condition. So definitely there is a risk of overtreatment, but in my opinion, the risk of not treating this patient is higher. Moreover, the EUS could help avoiding unnecessary ERCP. So I think that the balance is still in favor of EUS.
Yeah. I think, Peter, here it's very important to remember that we're talking the context of our study and the ESG risk stratification, which is for patients with suspected choledocholithiasis going for lap chole. We're not talking about pancreatitis where you can wait for small stones, no cholangitis. It's a question of patients going for lap chole. So when patients are going for lap chole, our surgeons want to be sure that they don't have a CBD stone remaining there, because after lap chole you can have consequences of a leak and so on with that. So if you tell them with a stone removed, then of course for them it becomes much easier. So it's in this context we must look at this study and the ESG recommendations, and not in the context of suspected pancreatitis. And like Andrea said rightly, that of course we know that there can be other consequences if we keep waiting.
True. Yeah, that's also important to keep in mind. Yes. Maybe a final question. You mentioned that already. What was the interval between diagnosis and therapy? Was it standardized, or was it up to what happened?
In all the patients, it was within 72 hours. So in all the patients, it was within, yeah. So it was standardized.
Okay.
Okay. So I think we have answered almost or discussed all questions and comments in the chat. And looking at the time, it was very, very precise. And thank you so much for both of you for this great presentation of the paper and your discussions on this topic. So thank you for having you here this evening. I think the paper of the month is meanwhile a very popular webinar. Even it is summer, people join us, and we would like to thank you for being here. We would like to thank our participants for joining this evening, and would like to invite you, and maybe Peter, we can show a couple of slides. Yes. So yeah, first of all, you have still the chance to visit the ESGE Days 2022 on demand until tomorrow. So take the opportunity
tonight. That's
stay online with us. But next slide, please. After 2022, the ESGE Days 2023 are coming, and the Congress is now, we are working on it. It will be in Dublin. It's a fantastic venue. So we really hope that everybody will come, and all these difficulties we had this year in Prague will be not next year. And especially we all cross the fingers and beg that this war will end, which definitely affected our Congress, and all the Corona was an issue. You remember in 2020, we had to cancel Dublin, but Dublin is happy that we are back. So please join us for next year in Dublin. And you see our society is growing very, very fast. We have now more than 4,500 members. When I became president, it was 2,000. So it's really a fantastic group, becoming larger and larger. And thanks to all working with us, I think we really are a huge family meanwhile. And there are many, many opportunities and advantages becoming member. So look at our webpage and join for membership. It's not so expensive, and all my team in Augsburg are almost members. So the boss of a department should really motivate his team to become members, especially for our younger fellows. Yeah, and then at the end, the next webinar is coming next week, the 6th of July, sponsored by Fujifilm, Endo Solutions for Upper GI, from screening to treatment. It will be chaired by Oliver Pech. He is very busy for the moment for ESGE. Thank you, Oliver. Speakers are Eric Schoon, Roberta Marcelli, and Edward Despot. And that's it from me, and I give back to Peter. And for sure, in the back, our team, David and Gabby, always do a fantastic job, that the organization is working very smoothly and without any complications. Thank you, Dave, and thank you, Gabby.
Well, also on behalf of myself, thank you very much for joining. Also, thank you very much for the speakers. I very much enjoyed this this paper of the month session. It was the 5th time that we organized this, and we very much look forward to after the summer when we will organize this paper of the month session again. Wishing you all a very happy summer for those who are planning to go very early. And of course, remember there's a next webinar next week. Thank you again. Thank you very much. Bye-bye.
Bye.
Thank you. Bye.
Thank you, everybody.